I am Michelle Rice, the Senior Vice President of External Affairs for the National Hemophilia Foundation, and I'm pleased today to have with me Val Bias, the CEO of the National Hemophilia Foundation, to discuss some of the issues surrounding the management of the hemophilia space. Good morning, Val.
Good morning.
So, Val, I would like to ask you, how do you see the role of insurers having evolved over the years with regard to ensuring adequate coverage for hemophilia medical and pharmacy benefits?
I think the role of insurers has changed because healthcare has changed. I think that the new healthcare structure has brought about a lot more accountability for the cost of patients, and I think that has an impact on how insurers look at bleeding disorders and the support of the products that control or assist patients with their bleeding disorders. I think that's been really the biggest change. 10 years ago, I think if you asked an insurer, how many patients with bleeding disorders they had in their plans, that they might not know that. And I think today they know exactly how many they have, and I think they know in many cases whether that individual is severe, moderate, or mild in terms of their usage of insurance coverage.
Thinking about the improved knowledge of the payer, what aspects of hemophilia care or management do you think that payers still need to improve or increase their knowledge around?
I think our initial discussions with payers that is ongoing is their understanding of care for people with bleeding disorders, that care is a multidisciplinary approach, an integrated care model where the patient has a relationship with not just a physician, but a nurse practitioner, a social worker, a physical therapist, and then additional team members as needed, orthopedist or a dentist. So it covers all aspects of their bleeding disorder. I think that has been a bit of not a mystery, but something that they weren't intimately involved with, knowing how that works, how a patient is followed from their birth through their adulthood period. And I think that's something that we continue to teach them about, and why that's important to the continuity of care for the patient, as well as cost containment.
Speaking of cost containment, what would you say to senior management from a health insurance company to help them understand how the use of coordinated care or multidisciplinary care could lead to decreased cost or potential cost savings?
What I would say to them is, once you have trained a patient, and again, the integrated care team is the group that's going to train the patient to effectively infuse their product on a regular basis to achieve a level of compliance that's going to control their bleeding disorder. So once that happens, you want to make sure that patient remains within the plan that the physician and the patient have designed to control their bleeding episodes. And the best people to monitor that is that integrated team. They're going to know, based on the number of bleeding episodes the patient has, when they are off of compliance. In collaboration with the pharmacy service, they're going to know how much product that they use at any given time and whether that is an unusual curve. And that's not just to account for how much product they're using. That's in many ways to account for their state of health. If someone is using more product than was prescribed, that means there's some problem with their bleeding disorder that probably needs medical intervention, or at least a discussion with their physician and or integrated care team to make an adjustment to their care. And that's why that relationship is so important. That's why that integrated team is so key to not only the care but cost containment for the patient.
More and more commonly, specialty pharmacy and 340B pharmacies are more active in the management of their patients that are receiving product from them. So can you explain a little bit what value does the pharmacy provider bring to that patient's care?
Well, often the pharmacy provider is the distributor of the product, so they are a direct line to know how often the product is delivered to the patient, what level they're likely the first contact, professional medical contact that's going to know when usage goes up or usage goes down based on delivery patterns, depending on how in touch they are with the patient, and often that is related to disease, how severe the disease is. They're going to know many things about the patient and their habits of treatment, their need, if let's say it's a child, whether or not that parent is more or less comfortable with doing the infusion themselves, or whether they're going to need to go to the emergency room every time that it's done. So the pharmacy then becomes a critical contact for the integrated care team, as well as the distributor of the product. You have to remember that clotting factor is not picked up at your local pharmacy. It has to be delivered to your door. In many cases, it has to be refrigerated or packaged in a way that provides safety for the product, preservation, the quality of the product. So specialty pharmacy and pharmacy providers at the treatment center are key to the patient's care.
Why do you think it's important for the National Hemophilia Foundation to be involved in the conversation and involved in the education of the managed care and payer professionals?
I think the foundation has a unique opportunity to have a long-term view of the progress of the products over decades. I think we have a unique relationship with researchers and physicians about the application of those products, knowing kind of what's ahead, or what we hope for, because we advocate for what we hope will be better treatments for the patients. I think it's important in terms of institutional memory for our federal partners to know where we've come from and where we're going. There was a time in this country when bleeding disorders had no treatment at all, where the life expectancy was 20 years of age. Today, the life expectancy is normal, and there are a number of treatments available to patients. I think some who are new to these disorders and the treatments available to them assume that one size fits all, where the foundation can clarify that there are many types of mutations that affect people and cause bleeding disorders, and that they all are unique in many ways to the individual, and therefore different treatment options need to be available. I think we're in the best position to communicate that from our decades of experience in representing these patients, from our relationship with researchers in terms of advocating for better treatments, better applications for the patient, and their ability to lead sort of normal and effective lives, not only professionally, but with their families.
Looking into the future, and as we know that hemophilia care is changing, what would be your ideal vision of disease management, peer relations, collaboration look like?
I would say we have to continue to work to make it seamless, that we need to diagnose as early as we can, that we need to adopt a treatment plan that best benefits the patient, that we need to not fear adjusting that plan based on the patient's growth and maturity and disease progression, so that we limit the impact of that disease on the patient's life as a whole. I think there needs to be collaboration between payers and physicians and the patients themselves to achieve that balance. I think those who are funding the reimbursement, whether they be payers or whether they be state and federal reimbursement groups, as well as private employer groups, need to use the foundation and other resources to continue to meet and debate the best way to treat the disorder. At the end of the day, what you want to make sure that you have is a collaboration that supports the patient's health. I believe that a healthy patient is a contributing member of society. I believe that a healthy patient leads a vibrant life and has a vibrant family that produces children that go forward, who live without the disease, but also live with the entirety of their parents' attention. Having grown up with a bleeding disorder myself, I know that there's a tendency to provide for your family, come home, sit on the couch, get enough rest so that you can get up and go to work the next day. And that unique interaction with your family around playing with your kids in the backyard, doing those extra activities with them isn't necessarily a top priority for you because you need to provide for them. And that might mean a little more rest and relaxation in order to keep your joints going so that you can, achieve what all Americans expect to be normal life. And I think that should be our goal in terms of collaborating with payers, physicians, that integrated care team, the National Hemophilia Foundation, passing on the knowledge that we have about the products, how they work, how they continue to improve, and how we can best use them to support the patient and provide some consistency of cost as it relates to caring for the patient.
Well, thank you for your time today, Val. I appreciate it. I appreciate your insights.
You are welcome. My absolute pleasure to talk about the people that we represent.